So, we have two uh, moderators, Dr. Sarath and Dr. Jayarani. They are pillars of TAPISAR. Dr. Sarath Batina is a consultant reproductive medicine specialist at Indigo Women's Hospital, Chennai. He had his IVF training at National University of Singapore under Professor Ratnam and King's College School of Medicine, London under John Parsons. He was in charge of IVF unit at Apollo Hospital from 1989 to 2016. Then he started his own center. He is responsible for first gift baby of Tamil Nadu in 89, responsible first IVF twins of South India in 1991, first IVF baby from frozen semen sample in India. He was member of many societies. He started postdoctoral fellowship. This is affiliated to Dr. MGR Medical University in 2012. He is a PhD guide. He presented several papers in national and international conferences and contributed chapters in textbooks. He is certified robotic surgeon by the surgeon. He was awarded Ugad Puruskar Millennium Award by Madras Telugu Academy in 2000, and also he was Young Achievers Award. He's one of the active members when we organized AICOG in 2015 and also ISAR Annual Conference in 2015. Next is Dr. Jayarani Kamaras. She is the chief consultant in infertility and high-risk pregnancy at Akash Fertility and Hospital, Chennai. She is an elected member of World Association of Sexology and managing committee member of OXY. She had so many awards. Rajamani Janakiraman Prize in Gynecology and Obstetrics, Vadamalai Endowment Prize Gold Medalist in MBBS University first, and also Anantachari Prize for Medicine in MBBS. She was Gold Medalist in DGO, and also she was awarded the Women Year of the Award 2010 by Lions Club, Achievement of Human Service Award by Exonora in 2010, Mega TV Women Achiever Award in 2011, Nalam Hospital Women Achiever Award 2011, Best Doctor Award in 2012 by the Dr. MGR Medical University. Now you all know that why communism has entered into India, because one person itself takes all the awards. That's the reason. Okay, I request Dr. Jayarani to introduce the first speaker and start the.
Thank you, sir. Thank you for the nice introduction. I welcome all the international faculties and I welcome all the delegates. And I thank you, Sanjeeva sir, for making us a part of this wonderful TAPISAR CME. And I have the great pleasure, pride and honor to introduce our own countryman who is presently a subspecialist and associate professor in reproductive medicine, Nottingham University. He's heading the Fertility United unit in Leeds and IVF consultant in Royal Derby Hospital and Care Fertility Center. He has graduated from Kerala from the Calicut Medical College in 1994. He has completed his MD from Pune and DPNB from Delhi, and his MRCOG in 2002 from London, and PhD he has done in Nottingham, and he did his PhD in standardization of ovarian reserve assessment, and he has published over 100 peer-reviewed research and review articles and authored more than 40 book chapters and edited 4 textbooks. Very interestingly, the gynecological ultrasound scanning tips and tricks from Cambridge University that was published in 2020, and ultrasound in subfertility, routine application and diagnostic challenges, a practical guide of setting an IVF lab and embryo culture systems and running the unit, and management of pregnancies following ART, won BMA highly commended award in 2017. And he's a member of the committee of the NICE Fertility Guideline Committee of 2016. He's a topic expert member of this committee. And he's also a NICE Center of Guidelines 2017 to 21 member who is an expert advisor of the current expert advisor of the UK NICE Center. And also he's the current member of the Scientific Advisory Committee for the RCOG between 2016 and 2019. And he's a editor and member of RCOG Quality Assurance Committee. And he's an associate editor of OBGYN, that is an RCOG journal. And we Tapizar, we cordially invite you, sir, as well as we have a great pride to have you here to deliver your lecture on 3D ultrasound in subfertility. We all know the 3D ultrasound is a real, it's a real important tool for all the fertility specialists who are practicing basic IVF as well as advanced ART. And this gives a lot of meaning for the real practice. So in this content, I would like you to present your presentation on 3D ultrasound in subfertility, sir. Over to you, sir, Dr. Jayaprakasam Khanna.
JP, you can share your screen.
I will, sir.
Yes.
So we know that ultrasound is absolutely essential tool in a fertility unit. And we do use it for baseline investigation to rule out uterine and adnexal pathology, which may be detrimental for fertility. And we also use it for monitoring fertility treatment, procedures, and also assessing and grading treatment complications. And for these, our conventional 2D ultrasound is absolutely enough. But having said that, 3D may offer some advantages by improving the image quality and therefore providing some more information for improving the diagnostic accuracy and also for making decisions about management plan. And this is because 3D ultrasound offers some advantages over the 2D technique in mainly of 4 basic steps: the data acquisition, data storage, and more importantly on image displays and post-processing. These are the key for improving the image quality, spatial orientation, and providing some additional information. It also has got the advantage of providing data analysis a bit more objectively and reproducibly. And I'll go into detail in all these 4 steps. So first of all, even before starting 3D ultrasound, having good knowledge and experience in 2D ultrasound is absolutely adequate. And we have to optimize the 2D setting to begin with, looking at the scan angle, depth, focus, frequency, and gain, principally, and get the best possible image that we can before moving on to 3D scan. And when we are doing a 2D scan, I'm using as a pair because which is more or less close to the shape of the uterus. We get longitudinal scans first, or initial slices with the 2D scan in a longitudinal plane moving from one side to the other, and you turn the probe 90 degrees and you get the transverse slices at different time points. And with the 3D machine, I'm sure those who are doing the ultrasound machine will be aware about the tip of the probe has got the motorized ultrasound emitter, which emits the ultrasound waves in both longitudinal and transverse planes. And once the image comes back to the machine, the hard drive of the machine make a composite of this longitudinal and transverse plane, and then have the whole 3D volume. So once we get the best possible image, the 2 key things that we have to bear in mind when we are doing a 3D scan is the reference plane. And as you see here, the reference plane for a uterus, if you want to get, you get a mid-sagittal plane. So that is the central 2D slice point of the whole 3D volume. So when you get this reference plane, and if you set a set sweep angle on the machine, so for example, 90 degree, then it takes 90 degree equally on left and right side of this reference plane. Hope you all got it, and especially those who are doing the scan will be able to appreciate that. And the other thing that we always have to bear in mind is we have to stay still. We have to keep the probe stationary. Otherwise, the image that we capture can be blurry. Now I'll show you a video on this. So it's basically that we are starting the 2D scan to begin with, and we get the best possible image on 2D scan. And you see here how we hold the probe. So in a longitudinal plane. So once we do the longitudinal and then the transverse plane, you have to get where the mid-sagittal plane is on a longitudinal plane. And you press the 3D button, you have a 3D sector, you expand that 3D sector to enclose the whole uterus in that. So here, see, the box is completely enclosing the uterus. And again, you press the set button, it automatically sweeps from right to left, and then it gives us the multiplanar view. So it's a sort of a plane longitudinal, transverse, and the coronal plane, 90° to each other simultaneously. Once we get this image, you can rotate it in X, Y, Z planes. You can scroll through, you can zoom it, you can magnify it, and then you get whatever the slice you want from this 3D volume that you have already collected. So when we are doing a 2D scan, so see here, this is a 2D sagittal plane. So you're moving the probe from side to side, and you see there is a pathology, which is a submucous fibroid, and you can all appreciate that. And when we are doing a transverse plane is the key for mapping the fibroid, as you all know. So you see there is a fibroid at the top. So we get these images when you're doing a 2D scan in our mind, and then in our brain, we get that sort of a 3D model, where the fibroid is. And with the 3D scan, because it provides a coronal plane, so it's basically that the 3D, so longitudinal, transverse, and the coronal plane, because it provides a coronal plane, that clearly shows where the fibroid is. So you can see the fibroid is on the top left uterine angle. And there are so many post-processing software that is available within the ultrasound machine, which actually changes the contrast. So if you remember the old black and white TV, where we change the contrast to have some sort of a appreciation between two nearby structures. So you see here the light is put on, and you can see the fibroid very clearly on the rendering view, and that is on the top left-hand top uterine angle. We have other softwares called OmniView, where you can actually trace along the uterine cavity up to the cervix, and that gives again a coronal plane. And this is a rendering view, and you can see the fibroid a bit more clearly. And like MRI and CT scan, we can get multiple slices of this by using a tomographic ultrasound imaging. And you can choose this thickness, whether it is 1 millimeter or 2 millimeter thickness. And this also helps us. See here, you can see the anterior wall. You all agree this is the anterior wall and this is the posterior wall. So if you want to be precisely whether this fibroid is more towards posterior or more towards anterior, see here it is -4 to 4. So the fibroid is much more clearer in 1 and 2. So it's more towards the posterior wall. So it's a submucous fibroid, but more towards the posterior wall. But I would say it is more central, but a little bit towards the posterior wall. And there are other softwares called HD live rendering. This is again some of the softwares which is integrated in this GE machine. I'm not saying all machines, but the GE machine is the one that we commonly use. So you can see this is a septate uterus. This is one of our lady who had IUI without having any septal division. So the pregnancy is in the right hemi-uterus. And when you apply, even can you appreciate that even you can see the amniotic membrane, this is the yolk sac, this is a fetus. So there's so many post-processing that we can do using many softwares which is integrated in the ultrasound machine. This is an example of inversion mode where the hypoechoic area of the follicles within the ovary is converted into hyperechoic area, and this is an example of hydrosalpinx where the fluid is collected and see the retort-shaped uterus within the fallopian tube. We can also rotate these images, and this is called cine view. So this is a hydrosalpinx. You can see this is HD live rendering, and this is a follicle within the ovary, which can be rotated as well. The other big advantage is applying the 3D powered Doppler angiography. So here you can see the uterine vasculature, and when we are doing a 2D scan, you see you apply on a single vessel to look at the velocity waveforms. Whereas if you're applying the 3D powered Doppler angiography, you can get the whole vascular information around the uterus. So this is an image of a 3D powered Doppler angiography of the uterus where the grayscale information is removed. And you see the uterine artery on either side, and that is branching into arcuate arteries, arcuate and spiral arteries. This is an example of blood vessels around the endometrioma, ovarian cyst. This is around a tube ovarian abscess. So you can actually, this is probably not much useful in fertility, but much more useful in cancer diagnostics. But still, there has been a lot of potential for doing research and maybe even management as well. So moving on to other aspects like application of various other softwares for measuring data retrieval. So the data can be stored on a USB or on the hard drive. And because we can store the data, we can actually retrieve the data at a late time and do an offline analysis. We don't need the patient, and we don't have that pressure of measuring things when the patient is there. And we can use various softwares for a bit more objective quantification of the data. And because we can store the data, it can be used for telemedicine or teaching and research purposes. And this is something that I've done a lot of work from the research perspective. So this is an antral follicle count assessment using a 3D technique. So this is a 3D ovarian volume data sets. Patient has gone. We can do an offline analysis by scrolling through. See, now we can count the number of antral follicles from moving this pointer from one edge of the ovary to the other. And the other technique is measuring the ovarian volume. So normally in a 2D technique, we measure 3 diameters of the ovary and calculate the ovarian volume applying the formula, the ellipsoid formula, which is now integrated within any ultrasound machine. But considering that the ovary is an irregular structure, we can actually draw around the ovary using this software called Vocal, so accommodating these irregularities of the ovary, and then you rotate it around at 60 degree or 15 degree or 30 degree to 180 degree. And then ultimately, when we finish our measurements, and you get the 3D volume of the ovary with the 3D model of the ovary with the ovarian volume. And the studies have shown that this is more reproducible compared to a 2D technique. I'm not saying it has got the advantage of for a clinical use, but this has been proven to be more reproducible. Now for measuring the ovarian volume. So you see here, this is a 3D power Doppler data set. So you get the 3D power Doppler, you apply the Vocal, you get the 3D model, and there is a software called histogram, which is integrated within the 3D machine, and you apply that, and then you get the vascularity indices. So there are 3 vascularity indices, VI, FI, and VFI. And what this means, the vascularization index, or VI, means the amount of the Doppler signal within the ovary or within the region of interest, whereas the flow index is the intensity of the Doppler signal. So this is probably the number of vessels. This is probably the speed of the blood flow. So higher or lower, you can look at the vascularization, the higher blood flow, lower blood flow. This is faster or slower blood flow by looking at the flow index. And the vascularization flow index is a combination of the two. There is another software which has come up probably about just over 10 years ago, Sono ABC, which color codes this fluid-filled spaces, and in the fertility setting, we can use it for stimulated ovary where the multiple follicles are there. So you press the Sono ABC software, you activate it, and the square box will come, and you make sure that the square or the rectangle box is enclosing the whole ovary, and then you get the Sono ABC, that you get the output, which basically that it's saying is there are 25 follicles in this ovary, and you can see here the diameter of each of these follicles. So this also gets within a matter of few seconds. I'm not saying this is perfect. You may have to do some post-processing. So it's a sort of a semi-automated rather than completely automated. Because what happens is this may sometimes pick up if there is an artifact like a hypoechoic area outside the ovary, that also will be included as a follicle. So that is why you need to do a bit of semi-automation, making sure that there is no artifact or some other structures have been picked up on this to include in this output. So I've gone through all the principles of 3D ultrasound. What are the possibilities that we can apply? Now let us see one by one with regard to clinical applications. So first of all, the uterine anomalies. And uterine anomaly is probably the only clinical use that I can confidently say that the 3D is extremely useful. And 3D ultrasound is the gold standard diagnostic tool for uterine anomalies, full stop. I don't think that we need to do any combination of laparoscopy and hysteroscopy or an MRI unless there is an indication. So if you look at the prevalence of uterine anomalies, we have done quite a few systematic reviews and some primary studies as well. And this is looking at the prevalence of uterine anomalies. About 13% of population had uterine anomaly, but considering arcuate uterus was the major one. And now, as you're all aware, this is now considered as a normal variant. So around 1.5% of the population had a significant uterine anomaly, and the septate and the subseptate. So that's probably constitute about 1 out of 100. And if you are looking at, is it important in diagnosing uterine anomalies? Yes, we know that most women with the congenital uterine abnormalities experience normal reproductive outcome. However, there is an increased risk of adverse outcome for these women, like miscarriages or preterm labor, and that depends on the type and degree of severity. And there are controlled studies. We don't have any randomized controlled trials, although there is one completed in Netherlands, which hopefully will be published this year. And the control studies have indicated that the hysteroscopic septal division reduces the miscarriage. And therefore, I'm sure almost all of us would be dividing the septum, especially with the background history of fertility or recurrent miscarriages. And what is a gold standard for diagnosing uterine anomaly? No doubt that the gold standard, the gold standard which has been there for a long time was a combination of hysteroscopy and laparoscopy. And the reason is because you can see with the hysteroscope an internal contour, and with the laparoscopy, you can see the external contour. And so if you have a combination of this, we can say that it is a normal uterus. However, on a hysteroscopy, if you're seeing this, and the laparoscopy, if you're seeing this, it is a septate uterus. And if you're seeing this combination, it is more of a bicornate uterus. And it is important that we need to distinguish between the septate and the bicornate. And this is obviously unicornate uterus. And when you're doing a 2D scan actually screen for uterine abnormality. So you see here, this is a longitudinal scan. So you doing a longitudinal plane moving from side to side. But the key for making a screen for uterine abnormality is a transverse plane. So here you see the turning the probe anti-clockwise 90 degree. You keep on looking at, I'm sorry, I don't know why this is not working. But you keep on looking at the endometrial echo, and if the uterus is normal, you will see only a single endometrial echo. So see this video where I'm just doing a longitudinal scan, turning the probe, and you specifically look at the transverse plane, and you see now the endometrial echo will be splitting into two when you're reaching to the top. Did you see that? And that is showing that, yes, the endometrial echo is divided, and therefore there is probably an uterine anomaly. So now doing a 3D scan, the 3D sector, which is expanded, and pressing the set button, and it is the ultrasound sweep is happening from right to left. And then you obtain the multiplanar view. And for diagnosing uterine anomaly, the coronal plane is the key, where you can see the external contour and you can see the internal contour. And the external contour is normal. The internal contour is very subtle dip, and that is more of an arcuate uterus, which is now considered as a normal variant. So this is a bit more clearer in this image. So see here the two endometrial echo that is completely divided by the muscular septum. And if you look at the 3D coronal view, see the external contour is normal, and the internal contour, the muscular septum, is dividing the uterine cavity into two. And that is the reason why we are seeing two endometrial echo on a transverse plane. And this is, this is a complete septate uterus. See, this is further shown in this subseptate uterus. So here, see here on a 3D, you can see that there is a dot, and that is actually relative to exact point in each of this plane. So basically that we are doing a longitudinal sagittal plane here is actually exactly at this level. And that is the reason why you're seeing the endometrium is far from the subserosal area. Whereas if you're taking a sagittal plane at this level, you will see the endometrium to the serosal distance is shorter. So that gives you a clue when you're doing a 2D scan. And when you're doing a 2D scan, again, you see the transverse plane, and that is the key where the endometrial echo is divided by the muscular septum here. So here we are actually having a cross section at this level, and that is the reason why we are seeing the two endometrial echo and divided by the muscular septum. And again, when you don't have a 3D, see, you have diagnosed or at least screened for some uterine anomaly. This lady has got some uterine anomaly, but when you get a 3D scanning coronal image, that clearly shows that the external contour is normal. The internal contour, there is a septum which is going probably up to the middle of the uterine cavity, so it's more of a subseptate uterus. So for diagnosing uterine anomaly, just for a few tips. So first of all, you make sure that uterus is seen in sagittal plane in its entirety like this. And make sure you get a good quality image. The screen is occupying more than 2/3 of the screen. The image is occupying more than 2/3 of the screen. And then you apply the 3D, you get multiplanar view. And you may remember that I told you about XYZ axis. So you have to rotate the image in XYZ axis, and there are 3 buttons in the ultrasound console. So you rotate it in 3 different planes to get an image something like this. So you can see even we have rotated it and clearly seen here the infundibular portion of the fallopian tube there. And then you apply, if you want to get a good rendering image like this, you put the rendering box, and when you press on the rendering box, you will see this like a square with a green line there. Make sure the green is at the top for this gynecological examination, and then you make it thinner. Then the picture quality will be much crisper. So you make this rendering box thinner, and you keep the green line at the level of the endometrium, and then you do a fine adjustments and fine rendering to get an image like this. So this is a normal uterus with a normal external contour and a normal internal contour. And these are some of the examples. Normal uterus, arcuate, you can see an internal indentation. This is a biconate uterus because the external contour, there is a dip. And also the internal contour, both the uterine horns are much more divergent compared to a septate uterus. This is a complete septate uterus where the external contour is normal, whereas compared to biconate uterus, here there is a dip. And if it's a uniconate uterus, you can see only a single uterine cavity. And see here the T-shaped uterus, that's also very clearly seen on the coronal plane. And if you're seeing a uniconate uterus, make sure that we are looking for a rudimentary horn. And you can see a rudimentary horn here. And if you're applying Doppler, you can see even a continuum of the blood signals on this. And one thing when you're doing a 2D scan that is not specific for 3D, make sure that we are going beyond the uterus, beyond the structure that we are seeing, especially for the uterus, because there could be an extra uterus or more commonly a subserous fibroid. So that is why you have to go beyond the region of interest. And you see here, you did see that 2 uterus there, and in a transverse plane, you will see 2 uterine bodies. And in 3D, sometimes it is not easy to get, especially if you can't enclose that in the 3D sector, because the uterus, the uterine bodies are more divergent, and you can't make everything coming into that 3D sector. And that is why I couldn't get a good image to show the uterus didelphys. And now, how do you classify? I'm sure you're all familiar with the ASRM classification, the AFS classification, the Yesterday classification, which has come up in 2013. What they have done is they have taken out the arcuate uterus because they have considered that as a normal variant, and then they have put in an additional classification called unclassified. They have changed some of the terms like bicorporeal rather than a biconvate. And they changed a hemiuterus rather than a uniconvate. And they have standardized the classification using a 3D technique. So basically get a coronal view, and what they have said is you use the uterine wall thickness as a reference. So basically you draw a line along the interstitial portion, you draw a line parallel at the serosal surface, and you get the uterine wall thickness. And if there is a septate uterus, so this is your line along the interstitial line. You draw a parallel line at the bottom of the septum, and this is the septal indentation. So if this distance is more than 50% of the uterine wall thickness, then that is a septate uterus. So if it's a bicorporeal uterus, in other words, biconate uterus, if this external indentation, this distance is more than 50% of the uterine wall thickness, then that is biconate uterus. But this has been criticized severely because you are using the uterine wall thickness as the reference standard. And if, for example, if there is an adenomyosis or if there is a uterine fibroid, that completely changes. And also the critics have said that majority of the arcuate uterus is now classified if you are using an Escher classification into a septate uterus. So the new one that has come up, the new classification, KUMI, they have come up saying that a simple method is to draw a line along the infundibular portion and measure this length. And if this is more than 10 millimeter, septate uterus. And this is what we have been using for the last 10, 15 years. So just to show that the 3D ultrasound is absolutely the gold standard, proven in this systematic review and meta-analysis. We use the MRI if there is an additional problems. So we could say for the diagnostic purposes, for asymptomatic women and low-risk women, you could use a 2D scan and HSG or good screen as screening tools. Use the 3D ultrasound for symptomatic women, high-risk women, recurrent miscarriages, asymptomatic with suspected screening tests, the 2D scans and things. and you use the MRI and a laparohysteroscopy for diagnostic purpose of uterine anomalies if you are suspecting some complex abnormalities or if there is a diagnostic dilemma. And when we diagnose any uterine anomaly, see here, nearly 19% of the patients have been associated with some form of renal abnormalities, and the most common one is a unilateral renal agenesis. And in this study, if somebody who has got a uniconate or a hemiuterus, around 30% have had a renal abnormality, and about 25% of people who have had biconate uterus, or bicorporeal uterus, have had urinary abnormalities. Moving on to fibroids and polyps. Fibroids, it's very common, and once we diagnose a fibroid, we have to see where it is exactly located, especially in relation to endometrium, and that is because the submucous fibroid affects fertility, whereas intramural fibroids affect fertility as well. Subserous fibroid are innocent. And if you're treating, we know that submucous fibroid, yes, if there is a submucous fibroid, it is best to remove it. It has shown that there is benefit. And if there is an intramural fibroid, the evidence is unclear. But having said that, majority of us would operate if the fibroid is larger, generally around more than 4 or 5 centimeters in size. And ultrasound, 2D ultrasound is absolutely enough because of you're looking at all the features of hypoechoic area or well-defined, smooth outline. And in case if the picture is not clear, you always use a penetrative mode on ultrasound. And sometimes we may have to use an abdominal scan because it is more penetrative or because of it's a lower frequency. But as I shown you this picture before, the 3D ultrasound, because of its advantage in showing the coronal plane, we will be able to clearly diagnose the fibroid and locate the fibroid. See here, probably with the 2D longitudinal scan, we know that there is a fibroid, but we don't know precisely what's its relation to the endometrium. And with the coronal plane, you see that there is just a gentle indentation. See here, the uterine cavity is not clear. The 3D may give a bit more extra information. And this is a complete, type 0 submucous fibroid. And on a hysteroscopy, this is clearly seen with a very short pedicle. And you could apply saline infusions on a hysterography. I tend to use an IUI catheter. You insert and instill some saline. And if you've got a 3D machine, you just need to put it for a small amount, couple of mLs, and do a 3D scan pretty quick, 20-30 seconds. You get the image and you can manipulate subsequently. You don't need to push fluid and you don't need a patient there because you've already got the 3D volume properly if you have taken, and you can go back and see here there is a polyp. And saline infusions on a hysterography probably reduces, there is evidence that reduces the number of hysteroscopies that we use. Endometrial polyp, we always generally do in the follicular phase because it shows a trilaminar endometrium, and the polyp will be hyperechoic, and the midline echo is lost here. And if you put a Doppler, you will see a pedicle sign. And with the 3D scan, you may be able to get some more information in terms of where the polyp is. See here, it's a broad-based polyp on the left uterine wall. This is more of a perfectly in the middle, probably by a small polyp. And if you apply the Doppler, this is a polyp which is completely enclosed, completely inside the uterine cavity, and a pedicle sign that is seen there. Moving to adenomyosis, this is also an area where 3D can be applied. Adenomyosis, there are quite a number of features. One of the features is a globular uterus, anteroposterior asymmetry. As you can see, there is not a clear definition between the endomyometrial margin. And there are a few other features as well. Heterogeneous myometrium, you can see a bit of shadows, parallel shadows. See here, asymmetry. There is sometimes you may see a myometrial cyst, hyperechoic symmetrical nodule. But one thing where the 3D will help is to look at the endomyometrial junction. So if you see the endomyometrial junction, a hypoechoic, which is absolutely normal, and the earliest sign of adenomyosis is the bridging of the endometrium to the myometrium. And that can be demonstrated by the 3D. At Nexel pathology, I don't think that the 3D will offer any advantage apart from getting some nice pictures like some of these. So you see simple cyst endometrioma. This you can apply hydrosalpinx where you will see those septa at different planes. Inverted mode, which I've shown you before. This is something showing that, in a tomographic ultrasound imaging where the ovary is seen and there is a cystic area outside. So you could apply this tomographic ultrasound imaging on a vertical axis and see that the structure of hydrosalpinx are different planes, and confirming that this is separate to the ovary. Now, moving on to the ovarian reserve assessment, where it can be applied, although I would say it is limited, and we know that there are, sorry, There are various ultrasound markers, antral follicle count, ovarian volume, and ovarian vascularity, but out of this, antral follicle is the best predictor of poor response and exaggerated response. This has been completely proven nowadays. And 2D ultrasound is absolutely enough for measuring the antral follicles, which is very simple to do, where you move the probe from one edge to the other and count the number of follicles. And with the 3D technique, you will be able to obtain the 3D model of the ovary. And once you get the 3D volume, you can scroll through and you can do a virtual offline analysis. So you're doing actually a 2D longitudinal scan as if the patient is there, but you're only using the either machine or on a laptop, and you can count the number of follicles. And with the SonoAVC, you can apply the one that I've shown you earlier. So you apply the SonoAVC button, you get a rectangle, making sure that the ovary is enclosed completely within this rectangle, and it color codes those follicles, and it, on the output here, 7 follicles there, and you will exclude this follicle because it is more than 10 millimeters, so you got 6 antral follicles in this. Although I've told you that this could be applied in general practice, it hasn't been proven to be much beneficial because, as I said, the antral follicles are much smaller, and there could be some smaller artifacts which can be picked up and give you a false number. So you have to do a lot of post-processing if you're applying SonoAVC. And it hasn't shown that whether you measure the antral follicles with a 2D or 3D or a SonoAVC, it doesn't make any difference in terms of predicting ovarian reserve. Follicle tracking, which is again much simple, where we use the 2D technique. You scroll through the ovary, count the number of follicles, and you could measure the follicles by a single diameter or 2 diameters. Majority of us possibly use the 2 diameters and take the average. And this is the area where we could apply the SonoAVC, as I've shown you before. And we have done quite a lot of validation studies on SonoAVC, whether it improves the clinical outcome. It doesn't make any difference in terms of a clinical outcome. The only thing is it may probably improve the workflow, because if you want to measure 25 follicles diameters in this, it may take a long time. Whereas if you're applying the SonoAVC, it potentially reduces time. And this could be useful in a busy IVF unit. What about procedures? The 2 key procedures, the egg collection and the embryo transfer. We have applied 4D technique where we can see a little bit more clearly, but this is like old movie where the frame rate is so slow and it is very unclear about where the needle is. So we couldn't apply. So we are so used to the 2D technique, and therefore there is limited application with the 4D. 4D is moving 3D. And what about the embryo transfer? Again, embryo transfer, I mean, ideally, if we can pinpoint where the point of maximum implantation potential is, like this, and we have applied this, and again, you can't see clearly where the catheter is. So it is a bit tricky to do this. So I wouldn't say that there is any benefit in using the 4D for the procedures. Endometrial receptivity, there's a lot of research happened, including ourselves, where you can measure the endometrial volume, and that has been correlated. Endometrial vascularity can be looked at as well. That has been correlated with the IVF outcome or fertility treatment outcome. Again, more than if you're comparing with the endometrial thickness, it hasn't been proven to be beneficial. So I would say it is limited, maybe potential for research. Nearly coming to the last slide. So for treatment complications, one of the things, because the 3D ultrasound can show us the coronal plane, and because of the coronal plane, we will be able to diagnose the interstitial pregnancy. So here, see, and that can happen in IVF pregnancies where heterotopic, see, one intrauterine, one interstitial pregnancy, where you can see the myometrium very clearly. The ectopic pregnancy is surrounded by the myometrium all around, and you can see there is no continuity of this interstitial ectopic with the endometrial cavity. And that is shown in this picture as well. And again, in this, see the myometrium surrounding the endometrial, surrounding the ectopic pregnancy. This is an area where you can rule out interstitial pregnancy as well. So this is one lady who has been referred to us because of suspicion of an interstitial pregnancy. But you can see here, this is an angular pregnancy. The pregnancy is still within the endometrial cavity, but this is more towards one angle. So it's more of an angular pregnancy because it is endometrial cavity. The myometrium is completely intact there. So it is not something that we need to worry about. You could apply in cesarean scar ectopic pregnancy, although you don't need a 3D, but this is a little bit more, the diagnosis is much more confirmed by looking at the location of the pregnancy right at the isthmial region. So to conclude, I've shown that the 3D ultrasound facilitates our improving the image quality, improving the spatial awareness, and therefore increasing the sensitivity and specificity of diagnosis. Because of the application of the automation, it may have potential to improve the workflow. And because we can store the data and we can do an offline analysis, it has got huge potential in teaching and research opportunities. And thank you very much for listening.
Jayaprakash, just stop sharing your screen. Jayrani?
Thank you, sir. Thank you, Dr. Jayaprakash, for this nice and wonderful presentation. And it is a very nice practical explanation you have given about how to use the 3D ultrasound, how to hold the probes. It's a very practical and very much nice videos you have given. And a very interesting about the arcuate uterus and the depth of the myometrial thickening to differentiate between the subseptate and the biquadrant, which is always, a doubt for all the people who do this transvaginal ultrasound. And it is very nice and interesting. Thank you so much. We have some questions for you. So
Yeah,
can
sure.
I go ahead with the questions?
Yeah, sure.
There's one question they've asked, I think, there is one, Coniro Gangadhar Rao. He has asked how 3D ultrasound can be used in azoospermia, how we investigate for dead spermatosomia, 50 Ang, and how to treat the dead sperms. It is very interesting. I really see something new in this. I think you can show or throw some insight into this topic of how 3D can be used in azoospermia.
See, I don't have much experience, I must admit. We have looking at some of the research element into it, basically looking at the blood flow. One of the things probably could be useful is applying the power Doppler angiography, looking at the vascularity within the testes, and then the better the vascularity, better the spermatogenesis around that area. And also looking at, probably you could use it for volume measurements, and that has been done as well as a part of research. So you can utilize a bit more accurate volume measurement of the testes. So those are the sort of potential thing. I don't think in clinical practice that we can apply. I mean, at least in I don't know whether anybody, you may have some experience, madam, but I don't have much experience in terms of it applying clinically. It has got research potential by looking at the vascularity and by looking and measuring the volume of the testis a bit more accurately.
I just want to ask you one question. Can you enlighten us about the junctional zone? Because this is the plane where the endometrium and the myometrium joins, and there is the initial beginning of adenomyosis starts. So nowadays, there are a lot of insights about the junctional zone. Can you highlight something about the junctional zone in 3D ultrasound and how it is important of beginning of an adenomyosis and progression of the disease? Does it have any role of differentiating by 3D ultrasound?
The junctional zone is quite an important area in terms of, that is again probably in a research setting, like in important area in terms of the endometrial receptivity, and quite a lot of interest is going into the junctional zone. And with regard to the adenomyosis point of view, as I mentioned in my lecture, this is the earliest sign of adenomyosis potentially is the endometrium bridging into the myometrium through the junctional zone. And if you look at the research studies as well, the diagnostic accuracy of adenomyosis, if you see the endomyometrial junction is being breached, then it is more of a adenomyosis. So the diagnostic accuracy based on just this single ultrasound sign, is quite good. Clinically, again, I have got a bit of reservation, maybe because I'm from the UK, we practice more of a conservative approach. So I'm not sure about the adenomyosis point of view, how we can apply. I mean, in clinical practice, if we diagnose adenomyosis, so be it. What can we do if you're going for fertility treatment? Probably we could try the long protocol down-regulating and then apply for the IVF rather than a short protocol. So those are the sort of a thing which I'm sure we all can debate. We have different opinions and different views of that.
Thank you, sir. And one more question I would like to ask you. How about your experience? in ultrasound mapping of fibroids? Because when you come across multiple fibroids, you plan for a laparoscopy, myomectomy, either hysteroscopy, both histolab. So how is this? Because every woman, we can't do an MRI. And what is your experience, both planning the mapping the fibroids before planning for a laparoscopy, and also intraoperatively during the laparoscopy, how you have a convenience of doing a ultrasound to map or locate the fibroids when you are doing a lap myomectomy?
With regard to mapping the fibroid preoperatively, obviously the ultrasound can be utilized, and some of the tips, and I'm sure there will be experienced listeners in this. But one thing that what I see is the transverse view is the key. Yes. Obviously, with the longitudinal plane, you will be seeing anterior and posterior wall. And what I tend to do is I draw a line, as you have seen the picture of the pair. The pair that you draw. So same way that you draw a picture, you see the anterior and posterior wall, and you draw in a transverse plane as well. And then the transverse plane is the key, where you will be able to get the right and left and the top and the bottom by different, at different levels. And then the other thing is you always reduce the frequency. So obviously when the uterus is so large, you will have to use the abdominal probe. And because if you're using abdominal probe, you have a better penetration. So as we all know, higher the frequency, better the resolution, but lower the frequency, the penetration. And always with the fibroid uterus, how many times that we have seen that the image quality will be very poor because the ultrasound wave is not traversing through the fibroid. So you reduce the frequency so that the better the penetration. So these are the sort of little things that we could apply, using all the buttons on the machine. From the intraoperatively, I do tend to use operative ultrasound for other things, like mainly for intrauterine adhesions, and also like evacuation of uterus and things for certain other reasons. But with the fibroid, we have the advantage for having a laparoscopy for almost all cases. Sorry, the MRI for almost all cases. But I assume probably you could still use the ultrasound because, especially that when you're doing a laparoscopy, you could still use an abdominal scan. You could use a transvaginal scan just in case if there's any fibroid, which is there. And possibly even if you want to confirm, if you're going in and if you want to look at a submucous fibroid, so you could use because you may breach the uterine cavity. So you could use a transvaginal scan and then looking into it. Even, using I tend to use a dye test, of course, with regard to this. I'm sure you all, just to confirm at the end, sometimes the endometrium, we may not be able to clearly see. So the same way that we can probably instill some saline as well, that may improve the visual image of the uterine cavity and its closeness to the myoma fibroid.
So one more question. So you were in your books, you have written about the tips and tricks. So most of the centers, they don't have a 3D ultrasound. They use more of a 2D ultrasound. So I would like you to give some tips to most of the doctors who use a 2D ultrasound to exactly what is the things that can give us an idea about the uterine anomaly with a 2D ultrasound, which can give them an idea. So, because sometimes when you see a unicornuate, it may look like the 2D, it is like a normal uterus, but there is some difference. So how you can, give a tips in 2D ultrasound to have an idea or hint of what is this shape of this uterus? Is it different from the normal? How you have you can give your tips.
Sure. Obviously, the transvaginal scan using a high frequency probe, make sure that, as I said in the beginning, to have a better quality image, using all the scan angle, depth, zoom if needed, and those kind of things. And then subsequently, when you're doing a scan, also the time when you're doing a scan. So if you're in doubt, the second half of the cycle is good in diagnosing uterine anomaly. That means in the luteal phase. The reason is the endometrium will be thick, and also in the luteal phase, we know that the endometrium will be bright, echogenic. So that gives a sort of a thing. So, the natural dye, the luteal phase, the endometrium will be white. The other thing is the transverse plane is the key for screening for uterine abnormality. So in the transverse plane, you move the probe up and down, and we go to come down from the fundus, and you look for the endometrial echo. you will see the endometrial echo. If you're seeing a completely single endometrial echo, then yes, it is likely to be a normal uterine cavity. I'll come into the unicornate, but that is the normal one single endometrial echo. And when you are reaching that endometrial echo at the top of the fundus, make sure that you're seeing both the tubal portion, where it goes, the infundibular portion of the tube, which starts as well. So make sure that in the transverse plane we can see that. So it is like our head and then shoulder. So basically the shoulder starts. That is how even the principle of you identify ovary, those who start scanning, you identify the shoulder where the tube starts. So the same way that you make sure that we are seeing both those shoulder, when they from the endometrium at the endometrial level. And then you're going down. And if you're seeing the endometrial echo is being divided at the top, then yes, there is a possibility of either arcuate uterus. But if it is only an arcuate uterus, that it is only a very subtle indentation, the myometrium coming in subtly. But if it is subseptate uterus, you will see that the endometrial echo divided a little bit further, probably up to the mid cavity. But if it is a complete septate uterus, you will see the whole length of the uterus is being divided by this septum going down. And then if you're going into the biconate uterus, with the septate uterus, usually the endometrial echo will be close together. Whereas if it's a biconate uterus, it will be far apart. So again, that is giving a clue that, septate and the biconate uterus. And with the uniconate uterus, you will see that it is a banana shaped or a single beak, because you will see only when you're doing a longitudinal scan itself, you will see that, oh, where is the uterus? And I can see that there is some sort of a problem, because I'm going into the left side. And if it is a left hemi uterus, you will see the uterus a bit more better when you are scanning on the left side. But if you're moving to the right, you wouldn't see. And if you're using a transverse plane, you will see, as I said to you about the shoulder, you will see, one hand is missing, one shoulder is missing. It's only deviating like a banana, only towards one side. So it's a single beak sign. And that is clearly demonstrated on the 3D. But with the 2D, you will be able to get. But still, even if somebody who is very experienced can miss occasionally, but that is a sort of a thing. And as I said, when we are seeing a uniconate uterus, always look for a rudimentary uterine horn, just to make sure that there isn't any part of uterine body elsewhere.
Dr. Jairani, can I ask you one question?
Yes, sir.
Yeah, sure.
Yes, sir.
Dr. Jayaprakash, Dr. Sharath here. So I wanted to know whether 3D of any use for tubal patency test, like with HISCON or something. What is your experience? Or can we get with the hysterosalpingogram?
We could do a HICOC, and if you are applying the 3D, volume when the dye is going, and if you are lucky, and if you have taken that image at the time when the dye is going, then yes, you will be able to capture that. And I'm sure you will be familiar with Dr. Sonal Panjal. She has done a lot of work on that, and she has done a lot of work in showing even, getting a HD live view of the fallopian tube going in and things. I mean, in practice, I've seen that, it is regularly practicing, especially if it's a busy unit, probably limited use. But I wouldn't say it is perfect, but then it will be useful in getting some good quality images.
Thank you.
There is one question, sir. I think there is one question. One Dr. Femino, she is asking, when there is an ultrasound is sparsely available for ovulation study, which is the only day of an ultrasound you will advise? That's what the question that she has asked. Looks interesting. That's why I just asked you.
I think, I would certainly look into the cycle length. The cycle length, I know it is tricky because, ideally I would want to have at least one before and one after. So if it's a sort of a 28-day cycle, I would possibly, in our practice, what we do is generally assuming 28-day cycle, we start scanning. We want to reduce the number of scans, as you can imagine in the NHS, the cost. So we call them on day 12. So if somebody has got a 28-day cycle, but if somebody has got a bit more prolonged cycles, but it is consistent, then yes, 30-day cycle, you could probably say day 14. If somebody who has got 32-day cycle a bit more later, those sort of things. So at least we can see that the follicle is developing. And also the other thing is you look at the endometrium as well. It is not just looking at the ovary. because the endometrium, the pattern will be, it is like an hormones, isn't it? Like, you don't have to measure the hormones, to look at the estrogen. You just look at the endometrium and you can do a bioassay for the estrogen and progesterone. So you look at the endometrium, and if you see a absolutely perfect trilaminar appearance, then the estrogen is there. And if she is about to ovulate, then even looking at the endometrium, you can see that the progesterone makes the endometrium brighter, and you see the peripheral echogenicity. So the echogenicity starts from the outer aspects, and you will see that, and you can say that it is periovulatory.
Thank you so much, sir. Thank you so much for your wonderful presentation and very interesting practical tips for all the audience. And I hope that it will be one of the best tips for all the practitioners who are seeing this webinar. Thank you so much, sir. Over to you, sir.
Thank you, Dr. Jairani, for wonderfully moderating the session. Dr. Sarath, can you go to the next talk, please?
Thank you, Dr. Reddy, for giving me this opportunity to moderate this session and for the words of introduction. So now we'll move from the female partner to the male partner, and 40 to 50% of the couples attending our clinics may be because of male factor infertility. And we all know that ICSI has revolutionized the management of male factor infertility, but unfortunately, ICSI is expensive and many couples may not be able to afford the treatments. So in that scenario, and even government also is of no use, and insurance companies are not coming forward to help the infertile couples. So in this scenario, medical management will have an useful for the couple who wanted to have the baby and to alleviate their infertility. And now the speaker is none other than Dr. Ranjit Ramaswamy from USA. And Dr. Ranjit is presently the director of reproductive urology and associate professor at the University of Miami, Florida. And he had his training at Cornell Medical College and Baylor College of Medicine under the NIH sponsored fellowship and our scholarship, I can say. He has more than 200 scientific publications under his name, and he authored many chapters in the textbooks of urology and infertility. He's part of many editorial boards for many journals, and last year he got the award for Clinical Scientist Development Award, and many more he's going to get in future. So Dr. Ranjit Ramaswamy, he's going to talk to us on management of medical management of male factor infertility. Dr. Ranjit. And he's young, energetic, and full of knowledge. So we're all looking forward to. So those who are looking for gray hair and spectacles, they'll be disappointed to see this young, beautiful gentleman. Dr. Ranjit.
Well, thank you very much, Dr. Sarath, for the wonderful introduction, and thanks to Dr. Reddy for this webinar. I think it's fantastic, especially since given the current circumstances. I think education probably through this way is probably the only way for now. And then moving forward, I think we're going to see so much more of webinars being conducted and education being transmitted this way, as opposed to the live in-person conferences that we were doing. Thanks for the introduction and saying that I am young. So many of the youngsters now are on Instagram, and nobody wants to write emails anymore. I used to put my email address in the past. Nobody sends emails anymore. So if you guys want to direct message me on Instagram with questions, that's my handle, and you can DM me, and I'm happy to take questions through that way as well. Dr. Reddy has certainly established a very long relationship between us. We've been giving talks and exchanging information for the last 10 years with SRMC. These are some of his trainees. He established an exchange program where his postgraduates came and visited us in the United States. And Dr. Sarath has always been very kind to bring me Mysore Pak at every ASR conference. I'm going to miss those things. I think this year it's likely going to get canceled. There are talks that it's not going to happen. So certainly, we will miss those small things. And certainly it's been an enjoyable relationship to have both his postgraduates and for me to come and visit SRMC as well. And these are also other pictures of some of his other postgraduates that have come on. And we've certainly stayed in touch. You know, they don't just come and leave, and they always stay in touch and ask questions. And I really hope post-COVID, this will continue. You know, we can keep doing the webinars virtually, but hopefully once the COVID ends, we can restart the exchange program with the postgraduates. So certainly a wonderful opportunity to grow this relationship, and thanks to Dr. Reddy for really orchestrating something that was not possible 10 years ago with his trainees. So the goal for today is to basically present medical management of male infertility. Unfortunately, it's not very advanced, but at the same time, people always think that I can give some medications and make the sperm count better. And hopefully in the next half hour, I can tell you where we need to give medicines, where we should not give medicines, and where medicines really should not be working. So let's take hopefully a very common and a straightforward case in our clinics. A 28-year-old guy comes in with a history of infertility, really has no past medical history, no prior pregnancies. And his wife is 26. She's been worked up by the gynecologist and the reproductive endocrinologist, and all of the workup is completely normal. You do a semen analysis on him, and the concentration is 4 million sperm per cc. Normal WHO is 15 million sperm per cc. Motility is around 38%, so just a tad lower than the 40%. Morphology is normal, and the semen volume is normal. So basically, low sperm concentration and just a little low motility. The next step, if patients come from outside, you definitely want to examine them to see what's going on. If there are any correctable causes to try and give an explanation for the low sperm count. The other is you want to repeat the semen analysis in a lab that you trust. So many of these labs don't really do semen analyses on a regular basis. This is not just a commercial lab where you get hemoglobins and diabetes testing. This is a specialized laboratory. It has to be done by a specialized technician who knows what they're doing. So you examine him. He has 12 cc testes. Normal testis volume is around 16 to 20 cc. And the most important thing that you're looking for in young people like this is a varicocele, which is basically dilated veins around the testis that can increase the temperature of the testis and affect sperm production. In him, we did not see that. And you repeated a semen analysis, and it's actually fairly similar to the first one that you got. The concentration was 6 million sperm per cc. Motility was a little lower this time, around 22%, and morphology was 5%. So now we have this young couple. The guy has 2 semen analyses, and both of them have low sperm concentration. And on exam, you didn't see much other than a tad smaller testes. So before we move into medical management of infertility, I think it's very important that you understand the HPG axis, very similar to the female, but you have to understand where all the hormones are acting before you can start giving medications to these guys. So hypothalamus makes GnRH. It acts on the pituitary gland to basically make FSH and LH. FSH acts on the Sertoli cells and supports spermatogenesis, and LH acts on the Leydig cells inside the testes to make testosterone. And basically from the Sertoli cells are made inhibin and activin, which block the pituitary gland from making extra FSH, and Leydig cells make testosterone, which gets converted to estradiol, which then negatively feeds back on the hypothalamus and the pituitary gland to block GnRH and FSH, LH. So testosterone, when given exogenously, will certainly block GnRH and FSH, LH. Endogenously, the system is so tightly well-regulated that you don't see some of those effects. So we got a hormonal evaluation in our patient. Small testes, low sperm count. His FSH was 15. So normal value is around 2 to 8. It's a bit high. It's around 15. His LH came back at 5, and normal is around 2 to 8. And his testosterone was 244, and normal is between 300 to 800. And his estradiol was less than 20. So basically, this is a guy that has low LH and low testosterone, and his FSH is a bit high, indicating impaired spermatogenesis inside the testis. And we will talk a little bit about 17-OHP, and I'll discuss this a bit later, so we'll get back to this. So in him, the diagnosis is secondary hypogonadism. And let me discuss the different types of hypogonadism, and this is what is going to dictate whether you're going to give medical therapy or whether you're not, and what medical therapy you're going to give. So the different types of hypogonadism are basically based on just two hormones. It's based on LH and it's based on testosterone. Not on FSH, not on estradiol. It's based on LH and testosterone. In eugonadal men, the LH and testosterone are normal. Right? These are the guys that have normal hormone panel. In secondary hypogonadism, the LH is low and the testosterone is low. In primary hypogonadism, where people can have severe testicular failure like Klinefelter syndrome, the LH will be high and the testosterone will be low. We won't talk about compensated hypogonadism. This is a corollary to compensated hypothyroidism, but let's leave this alone for now. So for most patients, when we did a study last year, we saw that most patients will actually have secondary hypogonadism. They will have decreased LH and decreased testosterone. And very few patients actually ended up having primary hypogonadism with increased LH and low testosterone. So this is the pattern that you mostly see in clinic with decreased LH and decreased testosterone. So we always think low testosterone is a very common problem among adults, but it's actually not true. Nice review paper that we wrote, as well as a recent cross-sectional analysis that we did, which was published earlier this year, which basically showed that the low testosterone levels can happen even among adolescents and young adults in the US. So if you see the levels of young adults between 15 to 39 years old, we see that the testosterone levels in 99 to 2000 were actually pretty high. In 2015 to 2016, the levels have actually declined. And it's because these young guys are actually becoming more obese and their BMI is increasing. And this could be explanation for why the testosterone levels in these young guys are decreasing. So when you see this infertile men in the office, they'd be young. And if you think that testosterone level is going to be normal, even without checking it, you're likely making a mistake. So you do want to be thinking about low testosterone levels, even in the young infertile patients that you are seeing in the office. So hormonal therapy for male infertility is very straightforward. It's very simple. You just got to understand where it acts and how it acts so you can understand and give it appropriately. So the most important medicine that all of you are familiar with and have given it at some point is clomiphene citrate. Clomiphene citrate is a SERM. It basically blocks estrogen feedback on the pituitary gland and the hypothalamus and basically increases FSH and LH, increasing intratesticular testosterone. That's what you want to do. In medical therapy for male infertility, you want to increase testosterone production inside the testis, not in the serum, but inside the testis. And anastrozole is basically a medication that blocks the conversion of testosterone to estradiol, both in the periphery as well as inside the testis, again, increasing intratesticular testosterone production. We won't go into antioxidants today. This is a whole another topic, but just suffice to say that I give it in empirically, I give it for 3 to 6 months, and I give it for people who have idiopathic low motility. So if they have normal concentration, low motility, those are the patients that I give antioxidants for. And don't ask me one brand or the other. All of those seem to be okay. And last caveat, and this is probably the most important one, is when people take exogenous testosterone therapy, it is contraindicated in men attempting infertility. And I truly put long-acting because of a trial that we just published from the University of Miami last month, showing that short-acting testosterone therapy may be okay for men with fertility. But experimental, we'll talk about that data just a bit. For now, from this slide, I just want you to understand the mechanism of Clomid and the mechanism of anastrozole, because this is what's going to determine who you give it to and how much you give it for. So clomiphene citrate has been used in the treatment of hypogonadism. A study by John Monhall in New York basically showed that you can give it up to 3 years. You know, patients are always like, oh, should I stop it in 6 months? Should I stop it in 1 year? No, it's been given for 3 years safely, and the levels of testosterone can remain high, and satisfaction scores will remain high even when given up to 3 years. And we showed this study when I was in Houston, basically showing that this is a comparison between injections, gel, Clomid, and control, with Q-ADAM is the satisfaction questionnaire of hypogonadal symptoms, and in the red bar is the testosterone levels. Men always come in and say, Doc, I want my testosterone levels at 800. I want my levels at 1,000. I am going to be happier only when my levels get to 1,000. Really not true. Regardless of what the levels were over here that were attained with gel or Clomid or with the injections, which often the levels are pretty high, you see that the satisfaction rates are actually fairly similar. So just because you have a high serum level doesn't mean the receptor is going to work okay and the tissue level is going to respond okay and you're going to feel happier. You may mentally feel happier, but physically it's not going to make such a big difference just because you have a high level. So even with Clomid, even though the levels are not that high, you can still be happy with a low level. So medical therapy indications, right? So this is probably the most important slide of the whole talk today. If you have the first test you absolutely need to do is to do a low testosterone. Total testosterone, if it's less than 300, then you should start thinking about medical therapy. And I'll get back to this a little bit. We've started measuring serum 17-hydroxyprogesterone. It's something that we're all used to in checking in babies with suspicion for congenital adrenal hyperplasia. We've now started using this blood test in men with infertility to basically get an idea of what intratesticular testosterone is. And the last, and this is probably the most important one, is you need to have a normal or a subnormal LH, irrespective of FSH. So you guide medical therapy based on testosterone, based on LH, based on 17-OHP, not based on FSH levels at all. So who is the appropriate candidate for medical therapy? So this is a patient with oligospermia or azoospermia, and his testosterone level is less than 300. That's the first test you drew, correct? So it was less than 300. His FSH was high. We're not thinking about FSH. His LH was normal or subnormal. So that was 5. His estrogen was normal, and his serum 17-hydroxyprogesterone was 36, and normals greater than 55, and patients with low intratesticular testosterone. So this patient has low LH and low T, and he would be a candidate for Clomid. And I would treat him with clomiphene citrate 25 milligrams, so half a tablet every other day. Not the full tablet, not every day, because men don't need such high levels of Clomid and such high levels of estrogen, because this is not what they're used to. And this should be done every other day. There should be no drug holidays. Men don't have ovulatory cycles. You don't need to cycle them on and cycle them off. So just 25 milligram every other day, and repeat the semen analysis in 3 months and the hormone levels in 3 months. So let's flip this around a little bit. Let's say if the estrogen level now is very high, and now the T2E ratio is 2.7. This is a classic patient with Klinefelter syndrome. And when the estrogen is high and the T is low, then you can add anastrozole 1 milligram every other day, along with the clomiphene citrate 25 every other day. So only when the estrogen is high and the T2E ratio is altered and less than normal, then you should think about using anastrozole. Other than that, there's really no role for anastrozole in men with infertility. Certainly, you can add the Clomid with 25 along with the anastrozole. So why is estrogen so important? Often we think of testosterone is for men, estrogen is for women, and we need more testosterone, less estrogen in females. Very nice study done in Boston in 2013, where they took a whole bunch of college students and they gave them Lupron. They basically chemically castrated them, and then in one group they gave back testosterone, and in another group they gave back both testosterone plus Arimidex. And they actually saw that in the group that got the Arimidex, the red bars, the estrogen was undetectable, but they saw much worsening erectile function and much worsening sexual desire in men that got Arimidex. So you can't just give Arimidex 1 milligram every day to men and hope that they're going to be happy. Not a good idea. You need to. That's why the every other day dosing seems to work much better, because the estrogen doesn't get to undetectable levels. And you want to keep those estrogen levels within a normal range, even if you're treating men with this. Again, nice study that we did on men on testosterone therapy, where we showed, compared to age, compared to testosterone, we actually showed estrogen was the strongest predictor of libido. in men on testosterone therapy. So that message is, don't give 1 milligram every day. If you're treating anastrozole with men, make sure it's every other day and make sure the levels are normal. You can sometimes, I've even used 0.5 milligram every other day to try and keep the levels within normal limits. And this is probably the most important slide. Again, I keep saying this is important because everybody just gives out Clomid. Like, just take some Clomid, your sperm count will be better. They don't check hormone levels. They have no idea what to do with the hormone levels. This is the patient that Clomid is useless in. His testosterone level is completely normal. It's greater than 300. His FSH is high. We're not thinking about FSH. His LH is high, right? His LH is 14.5. This is the case of that compensated hypogonadism that I was talking about. His body is responding adequately to the testosterone and the low testosterone. His testosterone is normal. His LH is high. He should not be treated with clomiphene citrate, right? In patients with normal testosterone and elevated LH should not be started on clomiphene citrate. If their sperm count is low, you should start talking to them about IVF, right? That's the proper treatment. We are not going to give him medications to try and improve his sperm count. His body has done the job of improving the testosterone level to the max by improving LH. And so in him, giving him more Clomid is not going to make it better. In fact, it'll make it worse because now you're adding extra estrogen that's going to take the opposite effect and decrease spermatogenesis. So I think this is probably the most important stress that I can make is just don't give Clomid and anastrozole. Make sure you're checking these levels and doing this appropriately. So I think in our patient going back, he has low T and low LH. I think he probably will be indicated for clomiphene citrate for both the low testosterone level and the low 17-OHP level. So what is 17-OHP? I threw that out a few times in the cases today. Basically, this is the steroid pathway. This is cholesterol on the top, and this is aldosterone, estradiol, testosterone, and cortisol. 17-OHP is a nice precursor in the middle, basically in babies with CAH, 21-alpha hydroxylase deficiency, serum 17-hydroxyprogesterone will increase. This is what we check to make sure that we don't miss CAH. And we've actually published papers now showing that we can use this as a marker to monitor patients with hypogonadotropic hypogonadism. We won't get into that today. This is not that case, but certainly something to keep in mind for the future. So what is 17-OHP? Basically, nice study done in 2008. This is a contraceptive study where they took testicular sampling. So they took testis biopsies from men that were taking HCG. And on the x-axis here, we see 17-hydroxyprogesterone. And you see that when you give HCG, both intratesticular testosterone and 17-OHP increase. Very nice demonstration showing that with a serum marker, we can actually test what's going on inside the testis. And then we took that same information and we published this paper in Journal of Urology about 2 months ago now, where we basically showed that in men taking testosterone therapy, the 17-OHP exogenous testosterone, right? Injections, gels, so on, the 17-OHP actually declines, showing that you're not making enough testosterone from inside the testis. Whereas in the green bars, you see men taking HCG and Clomid, you see that the 17-OHP actually increases, telling you that Clomid and HCG appear to increase intratesticular testosterone. In men with infertility, that is the goal. We are trying to increase intratesticular testosterone. Sometimes we have no idea when these guys come in with high serum testosterone levels, if they are exogenously taking it, or if it's truly the Clomid, or are they taking both and they're cheating. And this is a very good marker to pick up and say, listen, we know you're taking exogenous injections, you're just not telling us properly. And we can easily find out with this one simple blood test, whether they're taking it exogenously or they're taking the Clomid and HCG like you prescribe. Again, we're always talking about, oh, I don't know if Clomid is going to improve the sperm count, right? You're like, just take it for 3 months, come back and let us see if the sperm count improves, say a lot of prayer, right? But this would be very nice where we say if the 17-OHP is less than 55, so serum 17-hydroxyprogesterone, less than 55 appear to be better responding to medical therapy than when it is normal. Makes sense, right? If your testes are not making enough testosterone, now you're giving medications like Clomid and HCG to improve the intratesticular testosterone, then certainly these men would respond better to therapy. So message, men with lower intratesticular testosterone appear to respond better with medical therapy. So if you have a guy with 17 OHP that's 36, which is less than 55, you can tell him, sir, your sperm count is going to improve 4 to 8 or 4 to 12 or whatever it is at a much higher chance than a guy that has 17 OHP at 100, in where the testes are making normal testosterone. In him, Clomid and HCG are probably not going to improve his sperm count as much as in the guy with low 17 OHP. So I think this is very important. Testosterone is a contraceptive. Exogenous testosterone, men taking injections, gels, I think it's very important to understand. We see so many of this now. They're getting it from the gyms, they're getting it from their friends, no longer with doctors' prescriptions. And we see so many of these guys show up in the office with azoospermia, right? Zero sperm count. And I think that is probably pretty devastating news, but certainly something that we should all keep in mind for. This is just experimental, and I truly don't want to convey this message, but I think this is where we're pushing the envelope. So in the United States, we have a nasal testosterone gel that's been approved since 2012. It's a 3 times a day application, so it's a little cumbersome for these young guys, but at least there's no risk of transference because it goes straight to the nose. If you look at the pharmacokinetics, it's basically very short acting. It goes up, the levels go up in an hour, and within like 3 hours, the levels are back to baseline within an hour. So it's almost on-demand testosterone, as opposed to injections and gels, which are give constant levels, steady levels throughout the day. And so what did we do? We did a phase 4 clinical trial at the University of Miami. We recruited a total of 40 men with hypogonadism who were 18 to 55 years old. We only included men with normal total motile sperm count, so TMSC greater than 5. So we didn't take guys who were infertile. We didn't take guys that were severely oligospermic or oligospermic, but truly took men with normal sperm counts. We see a lot of this. We see guys who have low testosterone, but they have normal sperm counts and they're symptomatic, and we're trying to put them on Clomid. We wanted to see if we can do something different in these men. And so this study just got published last month. So this is truly hot off the press, where we showed that when you give Natesto 3 times a day, the testosterone level increases from 230 to 600s. The FSH and the LH, normally you would think would completely get decline and become undetectable. We actually see that most of the men, these levels were normal. And this is probably the most important figure, is we actually showed that the total motile sperm count was maintained in 95% of the men. And this is important because normally when you give exogenous testosterone, the sperm count will actually become 0 in 65% of the men. But here, even though we see a slight decline, we see that 95% of the men were actually able to maintain their semen parameters. Again, remember, this is Natesto, nasal testosterone. This is not used to improve spermatogenesis, which we are trying to achieve with Clomid as in our patient. This is only to maintain this spermatogenesis. And I think it's important to distinguish between who you are treating. If a guy has normal sperm count and a low testosterone, this could be a good option. But if he has low sperm count, you need to be thinking about Clomid and anastrozole to try and improve his intratesticular testosterone. And finally, I'll finish. I think this is the wave of the future, is we need to be thinking about Leydig stem cells, because low testosterone has become such a big problem. We actually did a study where we injected mice under the skin. We took Leydig stem cells, and we showed that the cells can survive at the end of 2 months. And we actually also showed that from the autograft that these mice can make testosterone inside the blood. So in summary, I think using clomiphene and anastrozole is important, and you should use it only if T is low. HCG monotherapy is an option for men who have normal testosterone, and short-acting testosterone should be considered for spermatogenesis maintenance, not improving, but just maintenance. And I think future regenerative operations, things we should be thinking about is Leydig stem cells, because men who need to take testosterone, especially at such a young age, probably will require it for their whole life. And all of the treatment options that we have right now are not perfect. So I'd love to thank everyone for the opportunity. Certainly a wonderful collaboration with both SRMC and Dr. Reddy. And I really hope this COVID will end soon. And hopefully we can reestablish this wonderful relationship. And for those of you that want to email me or again, DM me with questions, I'm very happy to take, but thanks so much.
Dr. Sarath.
Yeah. Dr. Ranjit, thank you so much for a wonderful talk. It was scintillating and honey to the ears. So nice. We all thoroughly enjoyed your talk. No? So we do have a few questions for you. So there are so many antioxidants are available in the market. No? Do you have any specific recipe for your patients?
No, in fact, whatever the patients are taking, I let them take it. In fact, Sarath, there were two large studies that actually recently came out. One is the FAST trial, the folic acid and the zinc trial from the NIH, where they gave 430 couples placebo versus treatment. They found no difference in pregnancy rate at the end of 12 months. And then another trial that came out with the Conception XR formulation versus placebo, and they showed there was no difference in sperm concentration, motility, or DFI, or in the pregnancy rate at the end of 6 months, published in Fertility Sterility earlier this year. So after those studies, I am thinking that I don't think it's the problem with the supplement. I think when people take supplements, they shouldn't just take a supplement and go watch TV, right? I think it has to be combined with lifestyle modifications. If you're smoking, stop smoking. If you're eating unhealthy diet, stop eating unhealthy diet. If you're not exercising, go exercise, lose weight. I think you need to do all of those things together with the supplement to actually see changes in the sperm count and pregnancy data. So to answer your question, no, I don't subscribe to one. If patients are taking something already, I just let them take it on their own. But I say that it's not just the supplement that's going to do the magic. They need to do all the other hard work that comes with it.
What about steroids in your practice? Do you prescribe steroids for any of your patients? Infertile?
No, I think no. So I think if fertility is not in the concern, then I think taking testosterone for low testosterone is totally okay. That is safe. But if fertility is in the concern, unless they are part of the clinical trial with the nasal testosterone, I definitely don't give testosterone to any of the guys.
What about glucocorticoids for anti-sperm antibodies? Do you?
That's a good question. So for if you do see anti-sperm antibodies, then I do a course of prednisone, 5 milligram for 6 weeks. Not too long. So just 6 weeks, once a day, and then I recheck the anti-sperm antibodies. If the anti-sperm antibodies, if it's not getting better, then IUI is a very good treatment option for, agglutination and anti-sperm antibodies.
Dr. Jairani, will you put that question for Dr. Ranjit regarding that ultrasound in azoospermia?
Yeah, no, I heard that question. No, I'll answer that question. Yeah, you asked him that question. 3D, I think the question was gathered towards, can we use ultrasound to figure out where spermatogenesis is in men with azoospermia when you're doing testicular biopsies? Can we do ultrasound-guided testis biopsies to go and find the sperm? And many studies have actually been done on that, and they're unfortunately not associated. Just because you have more blood flow does not mean there is more sperm there. But whoever asked that question, very good question. I think that's where we need to take the field forward, we have to find out like a heat map, of the testis map to see where the sperm are, where they're not, because with this whole expedition of finding sperm from the big testis, very difficult. But it's a good question, but just regular ultrasound or 3D ultrasound has not made such a big difference so far.
Can I ask one question, sir?
Sure.
He's a good friend of mine, and he was my roommate during undergraduation.
Okay.
Yeah, thank you.
Nice.
So regarding hyperprolactinemia, sir, with the low sperm count, medical treatment play a role, no? So what is your advice and experience and treatment?
Very good question. So,
with the low sperm count.
Excellent. So if the prolactin level is greater than 25, then I start thinking about treating. And usually if the prolactin is above 50, you should think about getting an MRI. And usually I treat cabergoline, 0.25 milligram twice a week, and repeat the sperm count in about 3 months. If the prolactin level is not going down, then you can titrate the dose up to 0.5.
Ranjit, what is the level you will take LH to say it is low LH?
8, Dr. Reddy. LH less than 8, I think you should think about. So there is a difference between undetectable LH that happens in hypogonadotropic hypogonadism. I think those patients you cannot give Clomid to. Those you need to treat with HCG. But in patients who have LH between 1 to 8, where it is subnormal and accompanied by a low testosterone level, so T less than 300 and LH between 1 to 8, then you can give them Clomid. LH between 1 to 8, T greater than 300, do not give Clomid. That's how the body normally is.
One question from Dr. Sudha Jyoti. Can you give me a clinical algorithm for investigating a male infertility patient as well as clinical step-by-step treatment plan?
That's a whole nother talk, Dr. Reddy. You need to organize another webinar. With half hour, I can't teach the whole algorithm for infertility. This is just medical infertility.
Simple, you can tell few things. It is not possible.
Sure. I mean, I think the basics are, so many gynecologists are not used to examining men, right? I mean, I think gynecologists, if you're going to treat men, you should get comfortable examining men. You shouldn't just get an ultrasound. I think if you have a low sperm count, you should examine for a clinical varicocele, because an ultrasound detected varicocele is not a substitute, because then you don't know if it's a real varicocele or not. And then beyond that, I think exam, getting basic hormone levels, repeating the semen analysis twice, at least from one lab that you trust, I think is certainly very, very important. But yes, I mean, Dr. Reddy, apparently there are 1,100 plus viewers, so we should organize another webinar to organize this clinical algorithm.
Next I have notes, I'm going to put Ranjit name and Jayaprakash name only in all CMEs.
Dr. Ranjit, I have one more question for you.
Sure, sir.
Yeah. We had a patient who had pus cells and repeated cultures positive for different organisms. No? We kept on giving antibiotics, but he has come back with pus cells again and again. So we put him to the infectious diseases specialist, and he said, you forget about the antibiotic and just leave him alone. What do you say in that scenario?
So make sure whichever lab, I mean, unless it's your own lab, that its pus cells is truly white blood cells, because sometimes it could just be immature germ cells that they call as pus cells, and it's not really leukocytospermia. And then usually in those patients, persistent leukocytospermia, I do a semen culture. If the semen culture comes back with bacteriospermia, which it sounds like it has, you can treat it. If they are asymptomatic, I would just leave them alone. If they are symptomatic, then you should think about maybe there's some prostate abscess, get an ultrasound, see if there is any foreign body prostatic calculi that are causing this recurrent bacteriospermia. If they are asymptomatic and all that you need is for the clearance of the infection for IVF, then you unfortunately have to keep treating it until you get him negative before an IVF cycle. Beyond that, if they are asymptomatic, just leave them alone.
What are the candidates for IUI in your practice?
IUI, so TMSC, so total motile sperm count needs to be greater than 5 million. So as long as that is okay, then we usually proceed. And then obviously there should be no female cycle.
There is one question from
more questions.
Ask Sarath. Say would like to know how to help a couple with semen analysis showing asthenospermia.
Isolated asthenospermia. So let's say, for example, I think I showed you this 6 million sperm per cc, 22% motility, right? That is oligoasthenospermia. That you have to think about varicocele, hormonal causes. That's just overall spermatogenic decline. The more important one is where you see 10 million sperm per cc, 1% mortality. 20 million sperm per cc, 0.5% motility. And in those patients, you should be thinking about the sperm getting shared somewhere. And more often than not, it's at the ejaculatory duct. And in those patients, you should be thinking about doing a transrectal ultrasound. You should be thinking about getting a proper semen pH and a proper semen volume, and even thinking about seminal fructose testing, where you're now thinking about ejaculatory duct obstruction. And so isolated asthenospermia, very low motility and normal concentration, think about ejaculatory duct obstruction.
One more question. You started clomipin or HCG or anastrozole. When you will decide to stop and you will send patient to me for ICSI?
3 to 6 months. Hopefully that's a patient you sent to me, and then I send him back to you in 3 to 6 months. Okay. No, but 3 to 6 months, right? I think in 3 to 6 months, if you haven't seen a change, you should resort to IVF ICSI. Absolutely.
Tell me, primary hypo, how you will manage?
Excellent question. So LH undetectable, FSH undetectable, testosterone level very low, right? In hypogonadotropic hypogonadism, I usually start with HCG, 2000 twice a week alone. And this is dependent upon testis size. So if the testis size is greater than 10 cc, then just HCG alone is sufficient because they have germ cells inside the testis, decent testis volume. HCG 2000 every other day for 3 months to 6 months is probably sufficient to check sperm analysis. If the testis size is very small, so 2 cc, 4 cc nubbin, you need to most likely start with FSH and HCG together. So in those patients, 75 units twice a week FSH and 2000 every twice a week HCG, and then repeating semen analysis in 3 to 6 months. That's what I would do. You speak to Rupen Shah, he'll tell you some of these patients have to wait 1 to 2 years before you can recover their spermatogenesis. But certainly that's the option. So testis size, greater than 10 cc, HCG alone, less than 10 cc, HCG plus FSH.
Do you do genetic analysis for all these patients?
For hypo, I don't, Sarat, no. Only in patients with idiopathic testicular failure, where the FSH and LH are very high, testosterone's low, and azoospermia, I get karyotype and Y chromosome microdeletion. But if LH is undetectable, FSH is undetectable, and testosterone's low and azoospermia, then you know it's hypo. I don't do genetic analysis.
In your practice, what will be the percentage of sperm improvement in this group of hypo patients?
Hypo is very successful, right? I love hypo patients because 90 to 95% of the time.
The small
now you're putting caveats in it. If you have very small testes, then you know they don't have good germ cells. In those patients, you just need a lot of counseling and keep waiting. They will take 6 months, 9 months to actually recover spermatogenesis. And even if you get to 9 months and their FSH is normal, LH is normal, T is normal, 17-OHP is normal, then you can do a simple TESI and you'll find sperm. So those patients are pretty successful. You want hypo patients in your practice. It is all these idiopathic cases that are challenging.
Ranjit, there's so much of literature about oxidative stress and poor reproductive outcome. No? So, but you are not giving that much importance to this particular case.
No, I think we're sort of shifting the needle a little bit. I think oxidative stress and poor reproductive outcomes, I think that literature is still okay. What is not very good is we think antioxidant alone is going to help oxidative stress. I think that's where we're making a mistake. If you keep smoking and eating burgers and going to McDonald's every day and remain fat and take antioxidant, I think it's useless. You have to stop going to McDonald's, stop going to KFC and exercise in the morning and take antioxidant. I think then you can help oxidative stress. You know what I mean? I think that's what we are learning now, that just taking a simple pill, which we've always known, right? So, I mean, just taking a simple pill is never a solution to a problem. But here,
lockdown might have been a help then.
Yeah, I mean, I think that's what we are learning in a very hard way now, that with these negative data coming out with proper randomized trials, that these pills are not the solution to the problem. Just pills alone, I don't think are the solution to the problem.
Jay Prakash, you are still there?
Yes, sir. Yes.
Okay,
yes.
There are some questions are there. How will you follow up infertile couple during pandemic period? By Dr. Euphemia.
Sorry, could you repeat that? Sorry.
How will you follow up infertile couple during pandemic period?
You mean in our experience? We have just started. We have stopped seeing fertility patients for a long period of time during this couple of months. We had to reapply for the license, and we are just restarting. And we are doing now the virtual clinics by telephone or video. And then our initial plan is to start with frozen embryos, which we have frozen before, during the closure, and then gradually build it up. With regard to the COVID point of view, obviously one of the things, as you know, UK is quite significantly affected. And therefore, there is a possibility that patients may be asymptomatic, but they still carry the virus, or they may be pre-symptomatic. And because of that reason, there is a potential for other patients to get COVID. There is a potential for staffs to get COVID. And therefore, all patients who are starting treatment, we always advise them to be isolated for about 14 days until the day of embryo transfer from the time of gonadotrophin stimulation or from the time of FER HRT protocol. There are certain units where they do, there are different kinds of approaches. For us, this is the one, but we offer the antigen testing at the time of gonadotrophin stimulation. Whereas some other colleagues, they offer antibody testing at the time of gonadotrophin stimulation. And if they are antibody positive, then they don't do anything. Whereas if it's antibody is negative, then on the day of HCG trigger, doing another swab to assess to check the antigen, and then go ahead if it is negative with regard to embryo transfer. And we counsel all the patients about the limited evidence of what the effect of COVID, although whatever the limited evidence available is, it has shown that pregnant women are not more severely affected than the background risk. And also the babies, there isn't any increased risk of congenital abnormalities, although we do stress that the evidence is very limited, and therefore we get on with it. Is that the kind of thing that you were asking?
Yes, this is a delegate asked live. That's why I'm reading that question.
So one more question for Sir Jayaprakasham sir. Dr. Usha Sri Gandla, she has asked, how can we differentiate focal adenomyosis from intramural fibroid? Dr. Jayaprakasham.
Yeah, sure. I mean, one key thing for this is, obviously, you look at the grayscale features. The fibroids usually will be more or less uniformly homogeneous. It could be a hypoechoic or probably isoechoic, similar to the echogenicity of the myometrium, and there will be a clear border. Whereas with the adenomyosis, it will be heterogeneous, and also if you are scanning in the late luteal phase, as I said in the uterine abnormalities, where the endometrium will be brighter, same way if you do a scan in luteal phase, you will see those echogenicity of the endometrium, the endometrial lakes within the myometrium, and you will see parallel shadows that I have shown in one of my picture as well, like, in adenomyosis. But the other key thing is you put the Doppler on. If you put the Doppler on, you will see the Doppler signal around the fibroid. Whereas in adenomyosis, you will see the Doppler signal traversing the myometrium. So within the center of fibroid, there won't be any blood flow. So you will see the blood flow all around, like a circle. Whereas with the adenomyosis, you will see the blood vessels traversing through the myometrium.
So one more question, Dr. Nasreen. She has asked, please explain interstitial line sign in differentiating interstitial and angular pregnancy. Sure.
So the question, I assume, it is, what is the interstitial line?
Yes, that's it.
So it's basically, again, I thought I have shown in my one-off picture. So it's basically interstitial line is obviously the interstitial portion of the fallopian tube is where the pregnancy is. And if you see that interstitial line, that is a very few millimeter line between the endometrium, where the endometrium ends and where the ectopic pregnancy begins. So in between that, you can see a sort of a small line that is representing the interstitial portion of the fallopian tube. And you see the myometrium all around the ectopic pregnancy with discontinuation from the endometrial surface. Then that is a sort of an area where the interstitial sign.
How to measure the endometrial volume? That's a question from Dr. Lad Dakar. Endometrial volume.
Endometrial volume, using a 3D machine, you should have a vocal software, the same way that I've shown the ovarian volume. So you have to rotate, getting a 3D model of the ovary, 3D volume of the ovary, you measure the endometrium in the C plane, that is a coronal plane, and you draw around the endometrial area multiple times. You can actually set, those who are using the vocal software will be able to look at it, but in the machine, you can set it up at 6 degree, 9 degree, 15 degree, or 30 degree rotations, and you rotate it to 180 degrees. So you may have to do 6 times, 10 times, 12 times, the measurement, so that it accommodates the irregularity of the endometrium and at the end of it, you will have the endometrial volume. So it's basically using the vocal software either within the machine integrated, or you can use on a laptop as well. There is a software called 4D View. If you've got a Voluson machine, you can actually Voluson Club member, and you can get the 4D volume software installed on your laptop, and then use a vocal software, and then you can do that. To be honest, with regard to this, it does take time. We have done it mainly for the research purpose. In clinical practice, it takes quite a long time, and the reproducibility between two people who are measuring can be a bit varying. But generally, in the research purpose, it has been measured. Like what we say, endometrial thickness more than 8 millimeter is good, and same way that the endometrial volume more than 2 ml is quite good. So,
we have a lot of questions are there. I think we are exceeding the time. This half an hour, 45 minutes is not enough for the ultrasound or male infertility. We'll plan to arrange one whole day or off day like CME on ultrasound in infertility, and also male infertility we have to conclude. So Dr. Jayaprakash, thank you for sparing your valuable time, family time actually on Sunday, and giving excellent talk and interacting with our delegates. Thank you very much. We hope you will utilize your expertise in future also. Dr. Ranjit, thank you. Only one question I want to ask you, how many days you need to make a gynecologist into expert andrologist?
It depends on who the gynecologist is.
But I won't come and practice in US. I will practice only in India. Okay, thank you very much, Sandits. Everybody is the number of delegates is 1170, highest. Give a big clap, everybody, for our delegates. Thank you very much. Thank you very much for sparing like that. I wake you from bed. You are coming directly from bed and sitting and sparing your time. Thank you very much. Thank you, Dr. Sarath and Dr. Jayarani, for moderating excellently. And this all happened because of Bharat Serums and Vaccines. We should thank Mr. Kotabagi from Bharat and Serums for company for this educational grant and supporting this event, and also Mr. Ganeshan from Chennai, Divisional Manager, and Mr. Shashan and his team for technical support from Science Integra. Thank you, everybody. Thank you very much.
Congratulations, Dr. Reddy.
This is for all of us, Sarath.
Bye-bye.
Thank you.
Thank you so much.
Anything you want to tell? Anything? Just.
Thank you, sir.
Yeah.
Thank you very much. We'll close the session. And I want last thing. There is a 7th of June, another international CME. There will be from Brigham and Women's Hospital, Boston, attached to Harvard Medical School. There will be 2 talks. There's 2 speakers. One is Elizabeth Sarah Ginsburg. She is going to speak on ERT in women with advanced maternal age. And another speaker from same institute, Dr. Antonio Rosario Gargiulo, he is going to speak on fertility enhancing robotic surgery. So please block your date. 7th, same time. It started 5:30 p.m. and it continues for another CME. Thank you. We'll close.
Thank you.